Good evening, everyone. A very warm welcome to all our viewers who are joining us live. I'm delighted to host today's session titled over From Mutation to Medication and How Comprehensive Genomic Profiling Enables Personalized Lung Cancer Treatment. Today, we are going to explore some of the most common or most transformative advances in modern oncology: genomic testing, hotspot testing, and the growing role of liquid biopsy in lung cancer care. So, this is an area that is reshaping how we diagnose, treat, and even monitor progression and resistance in patients. Lung cancer today is no longer treated with the one size that fits all. We know that each tumor behaves differently, driven by unique genetic alterations. And to understand these changes, and tests like CGP and liquid biopsy have become essential tools. So to understand this transformation, we need to look deeper and not just at the tumor under a microscope, but at its genetic blueprint. So, over the last decade, advances like CGP, genomic profiling, and liquid biopsy have completely changed how clinicians diagnose and choose treatment and even predict resistance before it appears. So, through this discussion, we will break down those things and simplify the complex terminology, understand why genomic testing is increasingly become the backbone of personalized cancer treatment. Today, we are very fortunate to have Dr. C.N. Patil from Aster, Bangalore. A very warm welcome to you, sir.
Thank you. Good evening.
Sir, to begin with our conversation, we would like to know that many people hear the term genomic testing, but we do not understand that fully. So, what is genomic testing and why it has become such important in cancer care today?
Yeah, traditionally, the diagnosis of cancer is at the tissue and see the histopathology and say whether it's cancer or not. And if it is cancer, what subtype of cancer, whether it is a do some immunohistochemistry, that is protein expression on the top at that. So histology is what mattered the
Sir, I think there is some network issue.
Hello, am I audible?
Yes, sir, you are audible now.
Yeah, sorry. So in the present era, so genomic testing is very important because we are looking at the DNA inside the cancer cell. It's like looking at the fingerprint because each patient is unique and each tumor is unique, and we need to understand the biology of the tumor and we need to understand what is driving the cancer. So previously it was, as you rightly said in the introduction, it was like one shoe fits all and it was a blanket treatment. If it was non-small cell lung cancer, there was chemotherapy, and if it was small cell lung cancer, there was different chemotherapy. So we used to stop there. And then it evolved to adenocarcinoma, we have a different chemotherapy, and squamous cell carcinoma, we had a different chemotherapy. But now that is not the case. So we have to identify what is driving the cancer, what is the switch that is there in the patient which is driving the cancer, and we need to switch that off so that the cancer undergoes apoptosis, and then we need to develop newer targets and then also newer molecules to address those targets. And that is very important. That's why the genomic testing is very important, especially the poster boy for lung genetic testing is lung cancer, because we have so many druggable mutations in lung cancer, and the survival in lung cancer is improved by many months or years, I would say, with the development of this testing and also the drugs which we have for the targets which we have found. So that's why genetic testing is very important, because each patient is unique, each tumor is unique, and we need to understand the biology and also what is driving that cancer in that particular patient.
Correct. Thank you so much, sir, for breaking down so easily about genomic
It's
testing.
not audible.
So, am I audible?
It's not audible.
Am I audible now? Hello.
Hello.
Sir, are you able to hear me?
I'm not able to hear you.
Just 1 minute.
Sorry, it was not.
Am I audible now, sir?
Yeah, it's audible now. Sorry.
I think there was some network issue. Thank you so much for that wonderful explanation about genomic testing. So moving onwards, patient here often terms like CGP, hotspot testing. So what does these tests mean and how are they different from each other?
Yeah, this is what we do in the tissue. So in the tissue which we take from biopsy, that is the tumor tissue, we do testing for the gene expression. And if we are testing only for few common mutations, say we are testing only for EGFR mutation or ALK mutation, ALK translocation or ROS1 mutation, that is called hotspot mutation. It is just like screening and looking for highlights. Whereas comprehensive genomic profiling is looking at broader gene profile, like hundreds of genes together, and it is like scanning the entire thing. And we are not looking at specific mutations. It scans the entire genome and then gives us the mutation which are positive. So hotspot is like a snapshot, whereas CGP is like a full picture. So it is like cross-sectional. Hotspot is cross-sectional, whereas CGP is longitudinal. So that we don't miss anything when we do CGP. Whereas hotspot, there is a risk of missing some mutations. That's the difference between hotspot and CGP.
Correct. So as you were mentioning about hotspot test, so why might a hotspot test can miss certain mutations that CGP can detect?
Yeah. See, hotspot, we are looking at only particular mutation and the reads are not in the depth. And then we may miss mutations. And it is like hotspot, if it is positive, it is positive. But if it is negative, it doesn't mean that it is true negative. We may miss a lot of mutations. So when hotspot testing is negative, particularly in a non-smoker adenocarcinoma, we should take it with a pinch of salt. And the CGP has broader reads and deeper reads. So it's unlikely to miss any mutation or amplification in CGP testing. That's why hotspots may miss. So previously what we used to do when lung cancer is diagnosed, if it is adenocarcinoma, we used to ask for only EGFR mutation. And if EGFR was negative, then we used to go for ALK. And if ALK was negative, we used to go for ROS. So this used to waste a lot of time. And then patients used to lose a lot of time. And then we used to miss on a lot of patients. And we were missing a lot of mutations. Whereas once CGP is done, it's very comprehensive and next generation sequencing, it is complete and the chances of missing any mutations are very less. And so we do justice and we save time and then we treat properly. There is no chance of any false negative in CGP testing. So that's the difference between hotspot and CGP. And we may miss a lot of mutations in hotspot testing.
Correct. Thank you, sir, for the differentiating factors between CGP and hotspot testing. So, talking about advantages or benefits, in which situation would a patient get benefit from? More from CGP instead of a hotspot testing?
Yeah, I would say in lung cancer, all patients should undergo CGP testing, not hotspot, for the reasons what I mentioned before. See, we may miss a lot of mutations. We had a patient who was non-smoker, female adenocarcinoma. The chance of having one targetable, that is driver mutation, is very high in her. So hotspot mutation testing was done, and then EGFR, ALK, ROS, everything was negative, and she was receiving chemotherapy. And subsequently, since the PDL1 was 3 or 4% for her, so she was advised immunotherapy. So that's when we saw her and we asked for a Guardant CGP testing. And lo and behold, she had ALK positive lung cancer. So had she been given immunotherapy, that would have been detrimental for her, and she would have had a survival of maybe 6 to 9 months. And she had brain metastasis too. But now she is on lorlatinib because she's ALK positive. So the hotspot completely missed that, and she would have been in a different track of treatment and a dismal survival and poor quality of life. Now, 2 years down the line, she's having good quality of life. The cancer is completely under control with just a pill. So that's the difference what we make when we do CGP testing, because the hotspot, as I mentioned, can miss mutations. That's why it's important that CGP be done for all lung cancer patients, not in small cell. in non-small cell
Hmm.
lung cancer, especially if it is a non-smoker when we have very high index of suspicion of having a targetable mutation.
Correct. So, sir, as we are talking about CGP, so is CGP recommended right at the diagnosis or only when cancer stops responding to the treatment?
Now, CGP is very important at the diagnosis. So it may not be very important, say, in stage 1A, 1B, but nowadays, even in stage 2, 3, when they get operated, we should not be missing EGFR. So we should do that. Especially in advanced malignancies where we see 3B and 4, it's important for all patients at diagnosis. So it is very, very important. Even the International Association of Lung Cancer Study recommendation is to do CGP at diagnosis, so that we don't miss any mutation. And sometimes people may have complex mutations, rare mutations, and co-mutations, and sometimes different amplifications. So it's important that we capture everything at diagnosis. So it may take 3 weeks time, but it's very important we diagnose properly, label properly, so that we treat properly and achieve a good survival and good quality of life. There is no point in doing running in wrong direction with a high speed, so we will not reach the destination. So to reach the destination, you should be on target and then do proper testing. So that's why it should be done at diagnosis, and of course at progression we need to do CGP because there could be some change in the profiling of the tumor.
Correct. Sir, I agree with you that I think early diagnosis makes a person's life very simpler for moving ahead with the treatment. And as we move onwards, talking about some treatment decisions. So, how does choosing between CGP and hotspot testing influence treatment outcomes for patient?
Yeah, as I mentioned in one of the examples already, so
Hmm.
hotspot, if hotspot is positive, it is good. So it is less expensive, and hotspot picks up EGFR, say, then we are okay. Or hotspot picks up ALK, it's okay. But if hotspot is negative, it's not true negative because we are not seen the complete reads, the depth is not seen, all the genes are not studied, and also we may miss some co-mutations and also some bad mutations which may affect the treatment. So CGP will pick up all those things, and there is no chance of having a false negative in CGP. So if we have a patient who is all mutations negative in hotspot and give chemotherapy, that may be the wrong treatment for a patient what I mentioned as before. So ALK positive, then we don't give chemotherapy. So there is a lot of difference. Chemotherapy versus chemo plus immunotherapy versus immunotherapy, or just a pill. So it makes a whole lot of difference for the patient's treatment and also for quality of life and the survival.
Correct. So, sir, as you were mentioning about therapies and treatment, so could relying only on hotspot test delay or limit access to target therapies?
Yeah, we may miss a lot of mutations in hotspot. As I told already, if it's positive, we are okay. But if it is negative, we should not stop there. But instead of doing that, do hotspot. Then if it is negative, go for CGP. It's better to order CGP upfront. Even though it's slightly expensive, it's worth that much because unnecessary treatment will be more expensive than the test. So that's why we should do CGP for all patients of lung cancer. I don't think there is role for any hotspot mutation testing in the present era. Still, we are doing for cost reasons, but I think we should come out of that and then do CGP for all lung cancer patients.
Correct. Thank you so much, Dr. Patil, for enlightening us about genomic testing, CGPs, and hotspot testing. So, moving onwards to our next segment, that would include liquid biopsy in in lung cancer management. To start with, sir, what exactly is liquid biopsy and how it is different from a traditional tissue biopsy?
Yeah, liquid biopsy, I would say, is like an oxymoron. See, there is liquid and biopsy, but so people may get confused, but it's a very catchy word. But liquid biopsy means it's a simple blood test. It's non-invasive or semi-invasive because we have to just draw the blood and do the mutation testing or the gene profiling in the blood because the tumor sheds DNA into the blood and we may pick up those DNAs and then study them. So it's less invasive. So we don't have to put needle into the tissue and it may be painful sometimes, or and we may not get adequate tissue in lung cancer. Sometimes the lung cancers are deeply situated or in an area where the vessel is close or airway is very close, and we may not get a proper tissue. So in those cases, liquid biopsy is a boon, and then it's very easy also, and the results also are faster in liquid biopsy. So liquid biopsy means it's a simple blood test where we draw blood and look for mutations or amplifications.
Okay. Sir, as treatment modalities and treatment facilities in India are boosting a lot, so why is liquid biopsy becoming so important, particularly in lung cancer cases?
See, this liquid biopsy is not gold standard. Tissue is still the gold standard. But one thing is liquid biopsy can capture the tumor heterogeneity. See, there is a tumor like this, and we do a biopsy, and we are taking from one area of the tumor. So we may be missing mutations because the mutations may be harbored in the other areas of tumor. So there is what is called as tumor heterogeneity. We are not completely removing the tumor in advanced cancer. We are just taking a small tissue from a tumor. So tumor heterogeneity is not captured in tissue biopsy. Whereas liquid biopsy, because the DNA is shed into the tumor, is shed into the blood, so we will capture the tumor heterogeneity. So that's the advantage of liquid biopsy. One is it is non-invasive, it is easy to do, and the results are faster, and then it captures tumor heterogeneity. These are the advantages of liquid biopsy. That's why liquid biopsy is becoming important in the management decision of lung cancer.
Great. So, sir, as you mentioned about liquid biopsy and tissue biopsy and some advantages of liquid biopsy. So, in what situations would a liquid biopsy be preferred over a tissue biopsy if we compare
Uh,
two things?
yeah. See, ideally we should do both. Diagnosis should do both. Tissue and liquid should be done. As I said, it is both complementary. And liquid biopsy, we would get the result in 10 days. But suppose you have a deep-seated tumor where CT-guided biopsy is difficult, or patient is very frail and is on antiplatelets where biopsy cannot be done, or if the access is difficult, then in such cases, or if the biopsy has been done and the tissue is not adequate for processing for CGP, we often get this report of quantity not sufficient because it may fail the quality test. Then in such cases, or the tumor fraction is very low in the biopsy. So these are the situations where liquid biopsy is very useful.
Okay. Thank you so much, sir, for explaining that. As we are talking about cancer and detecting mutations, so can liquid biopsy detect mutations earlier or more easily than the traditional methods that we have been following since
Yeah,
many
liquid.
years?
See, the testing is evolving, getting evolved every day. So liquid biopsy is very fast. We get the results in 10 days. So we don't have to wait for 3 weeks or 4 weeks like what we do in tissue biopsy. See, liquid biopsy is akin to fishing. See, suppose you go for a fishing, then if there are a lot of fishes, the chance of getting the fish is high. But in
Hi.
that area, if the fish is not there, then you may not catch the fish. So liquid biopsy again is like almost like hotspot. If it is positive, it is positive. But if it is negative, it could be false negative. So we cannot rely only on liquid biopsy. It should be both tissue and liquid. And of course, in cases where tissue access is difficult or the quantity not sufficient, we had a patient recently where she was frail, elderly, 73-year-old. We did a tissue, and then there was adenocarcinoma. But the CGP, we waited for 3 weeks, and the report came negative, quantity not sufficient. So the patient also was unhappy, and the attendants were furious. And luckily, unfortunately, we had not ordered liquid biopsy on day one. Had we ordered that, we would have got the report in 10 days. But subsequently, at the end of 3 weeks, we ordered liquid biopsy. And after 10 days, we got the report that she is EGFR positive. And she is on osimertinib and is doing well. So liquid biopsy is very important. It should be done together with tissue. But if tissue is difficult or tissue quantity not sufficient, quality failed, liquid biopsy is handy. But again, if it is negative, it may be true, false negative. So that we should be cautious in that area because we may not be picking up the mutation. But if it is positive, it is definitely positive.
Correct. So I think liquid biopsy has many more advantages than the treatment modalities we have. So, sir, as a clinician, in your vast years of experience, you must have seen many treatment modalities growing and following. So, how does liquid biopsy help doctors to track how well a patient is responding to any treatment?
Yeah, traditionally we track the response of cancer by doing PET CT scan examination and then PET CT scan. So we cannot be doing PET CT scan every 3 months, right? So if there is suppose there is a test, simple test which can detect the tumor in the tissue in the liquid, and then we treat the patient and then we test the blood, and if it is negative, then we know that we have cleared the microscopic cells. So that is far more advanced. It is much more at the molecular level than at the morphological level. So liquid biopsy is important even for diagnosis and also targeting the treatment and also in following up the patient. Suppose the ctDNA test is there, circulating tumor DNA. If it's positive and we treat the patient, and in the subsequent ctDNA test, if it is negative, then we know that we have cleared the cancer. And serial testing, if it is negative, those patients do well. We have seen in colon cancer, it is evolving in lung cancer too. So ctDNA testing or liquid biopsy testing can be done serially, and then it's non-invasive. And then patient doesn't have to go for PET CT scan every time. So that's the advantage of liquid biopsy in monitoring the disease progression. Or suppose if the
Correct.
ctDNA was negative and then it comes back
Hmm.
again, and then it may antedate the progress by 6 to 8 months.
Okay. Thank you so much, Dr. Patil, for highlighting the medical facts that doctors and clinicians used for diagnosis and following the treatment for the patient. So, sir, talking about some safety point of view in a bigger picture. So, is liquid biopsy a safer or a more comfortable option for patient as compared to multiple tissue biopsies that are taken during the treatment course?
Yeah, definitely, because for obvious reasons, see, if tissue biopsy has to be done, it is invasive. Patient has to undergo through the intervention radiology thing and then CT scan and then locate the tumor and do biopsy. And it is definitely painful and invasive, and we may miss the tissue sometimes if it is deep seated. Whereas liquid biopsy is a simple office procedure where we just draw the blood sample and do the testing. So it's obviously convenient, less invasive, and can be done repeatedly and many times, and helps in diagnosis, monitoring of disease, and prognostication.
Okay. Sir, you were mentioning about patients. So, my generic question to you is that have you ever felt any barrier during liquid biopsy accessibility for treatment?
No, liquid biopsy is easily acceptable to all the patients because it's not invasive, and they are okay to
Hmm.
give blood sample because they would be anyways giving blood sample for all the routine blood tests.
Hmm.
And also, once we do, it captures the things very fast, and we get the report in 10 days. So it's easy to convince the patients to undergo further testing.
I think there was some network problem once again. We'll wait for 2 minutes for sir to rejoin.
Yeah, sorry. Yeah,
Yes, sir.
yeah.
You were mentioning about the accessibility and the
Yeah, it
patients.
is acceptable. It is
Hmm.
acceptable, and the results are faster. So there are a lot of advantages of liquid biopsy. So only downside is it can be false negative. So
Okay.
nowadays the chance of false positives are less because the tests have evolved. So what is called as chip, we can pick up the chip mutations, but they are all not very common now. But false negatives are common with liquid biopsy, especially if the patient shedding the tumor is not shedding the DNA into the circulation, or if the patient has deep like brain metastasis and it may not shed into the blood. So such situations, or if the patient has low burden of disease, where ctDNA may not be there in the blood. So in such situations, liquid biopsy we should interpret very cautiously. Otherwise, if the patient has extensive disease, a lot of disease burden, and then ctDNA comes positive, liquid biopsy comes positive, it can be taken.
Correct. So, sir, as a medical director and HOD of the department, how would you see, liquid biopsy shaping the future of lung cancer diagnosis and monitoring of lung cancer?
Now we are incorporating for all patients at diagnosis both tissue and liquid, and oftentimes we get the liquid biopsy in 10 days time, and we know what mutation the patient has, and of course we wait for the tissue report, but it has to be done at upfront at diagnosis, both solid and liquid. That's the recommendation even by NCCN and IASLC. So we do for all patients solid and liquid together.
Correct. So, adding on to this question only, so do you expect liquid biopsy to become a standard part of routine lung cancer care coming in the coming years?
Yeah, tissue has remained the gold standard so far, but liquid biopsy tests are evolving. The platform is evolving, and we are refining in our techniques. So it is going to become the standard of care. But of course, we cannot get away without tissue. Tissue will still be there. It will still have a role. But liquid biopsy will have a larger role in the future, especially in serial monitoring. Then on disease progression to do biopsies would be difficult. So then their liquid biopsy role will be more. And at diagnosis, I still feel both tissue and liquid will have a say.
Correct. Thank you so much, sir, for enlightening us. Everything about the liquid biopsy that one should know. So, sir, before wrapping up the things, we would like to have a quick rapid fire session with you. So, what would you say? Genomic testing in one line.
It's a DNA blueprint of the cancer.
Correct. Sir, hotspot versus CGP in another one line for both of it.
Yeah. The hotspot is few genes, whereas the CGP is full big genomic picture. It gives full genomic picture. So few genes versus full genomic picture. So obviously CGP is the clear winner.
Correct. So next one liner would be why CGP?
CGP to catch all actionable mutations.
Correct. So biggest risk of using only hotspot testing?
So we may miss a lot of mutations which may be life-changing for the patients. As I mentioned in our example, the ALK mutation was missed. So we may miss life-changing disease-altering treatment altogether.
Correct. So, sir, last would be biggest advantages of using liquid biopsies in managing lung cancer.
It's less invasive and the results are faster.
Correct. Thank you so much, sir, for those insightful and knowledgeable answers. It was, a very privilege of us to have you here and knowing about how genetic insights help clinicians as well as for choosing the right treatment pathways for patients. Thank you so much for giving us your time.
Thank you. Thanks for the opportunity.
Thank you, sir.